much. Is it visible?
Yes, sir.
Okay, so this is some sort of question and answer type. What is larynx and what is the extent? It is a musculo-cartilaginous structure lined by mucous membrane. And it is the beginning point of your respiratory tract. It extends from C3, C4 cervical vertebra to C7 cervical vertebra. In the cartilaginous framework is made up of 9 cartilages totally, 3 of them paired and 3 of them unpaired. So the unpaired ones are epiglottis, thyroid and cricoid. And the paired ones are arytenoid, corniculate and cuneiform. These are the structures that you can see this. So describe the thyroid cartilage and its significance. It's the biggest unpaired cartilage of larynx. Or if you know that this is the biggest one. And it has the shape of a shield. The word tyros in Greek means shield. The shield held by the Roman and Greek soldiers, which you would have seen in the movies. So it has 2 lamina which fuse in the middle, forming an angle of 90 degrees in males, which is also called as the Adam's apple, and 120 degrees in the female. And it has 2 pairs of horns, the superior and the inferior. And these inferior horns form a synovial hinge joint with the cricoid cartilage below. And so these are the superior and inferior horns on their chest. The cricoid means ring shaped. Word itself indicates that it's a ring shaped structure. There's a narrow anterior arch and a broad posterior arch. And during rapid sequence induction, applied over a cricoid to compress the esophagus to prevent aspiration. That is important. Another important is it is used as a landmark for giving your brachial plexus block also, because the nerve roots, they emerge at this level, C cricoid level, or the C5, C6, C7 nerve roots. They emerge between the intervertebral foramen, through the intervertebral foramen at this level. So cricoid is also can be used as a marker for identifying your brachial plexus when you want to give a crystalline block. And also it is one of the important ultrasonographic structure to find out whether your tube is in the placed correctly in the airway. And the structures and ligaments which hold the larynx, and even though hyoid is involved with the elevation and depression of the entire larynx, it is not considered as a part of the larynx. So if you see the cartilages, hyoid is not included. Hyoid is a bone actually, it is not a cartilage. And the trachea is the lower part of the continuation of the larynx. And all these things are held together by these membranes, which are called thyrohyoid membrane, trichothyroid membrane, trichotracheal ligaments, and are the 3 structures which hold the larynx and hyoid together. You can see all these structures being held. And the thyrohyoid membrane is of importance for us because this is the lateral conva, the greater conva of the hyoid bone, below which only the internal branch of the superior laryngeal nerve enters to supply the sensory fibers to the undersurface or the supraglottic area regions. So when you want to do any awake intubation, either fiber optic or blind nasal intubation, a successful block of this internal branch of the superior laryngeal nerve on both sides you have to do. So this membrane is of importance to us, the thyroid membrane, and it can be blocked below the greater convo of the hyoid bone for awake intubation. The next membrane is the cricothyroid membrane. This gap is very important for emergency front of neck access in cases of can't intubate or can't ventilate. What is Levitan's handshake? Dr. Kyle,
Yes, sir.
you know what is Levitan's handshake? Levatan. First of yes.
No,
Have you
sir.
heard this terminology?
No, sir.
Hmm?
No, sir.
No. Anyone else? Dr. Kamal Damodaran or Bintu, Anjani, next batch
Sir,
examples. Huh?
it's a maneuver when we do to align the larynx so that we can palpate both the borders of the larynx to make it position it in center, sir.
I am not able to hear properly. I don't know whether the audio is poor or what. I don't know.
Sir,
Okay.
it's a maneuver when we use to apply when we are planning for a front of neck access, placing both the middle finger and the thumb finger on either side of the larynx, placing the index finger at the middle of the trachea, sir. So we can just palpate and make sure that it is in center.
Yeah, you hold the larynx with the ring finger and the thumb, and then slide your index finger right from the hyoid bone on the top and slowly come down and pass through the thyroid and then palpate the cricoid and the gap between the thyroid and cricoid and mark that. Okay, this can be done in obese patients when you anticipate difficult airway. This can be marked and kept ready so that in case of emergency, you can immediately enter that membrane either to do a emergency opening or intubate through that for ventilation. Okay, so that is what is called Levitan's handshake. And the epiglottis is very important. Did you talk about the epiglottis, Dr. Kyle? What is the role of epiglottis?
Sir, it prevents from aspiration.
I could not hear anything you talking about epiglottis. That's why I'm asking. If you have described it, it's well and good. If you have not told, you have to add that to your answer. That is the reason why I'm asking.
Okay, sir.
So epiglottis is a leaf-shaped structure, and it's a cartilage attached to the base of the tongue and folds over the laryngeal opening to protect the airway during swallowing. So the most important function of epiglottis is to prevent your food or water, whatever you are taking, entering the larynx. So it protects the larynx by sliding over the glottic opening and directing the food towards the esophageal opening. And it is connected to both the body of hyoid and posterior side of thyroid cartilage. So the point where it is attached, you can see, is at the middle of the thyroid cartilage prominence. And anterior surface of epiglottis is covered by non-keratinized stratified squamous epithelium, and then gets reflected onto the tongue as what is called the glossoepiglottic fold and two lateral epiglottic folds. Median and lateral, two lateral epiglottic folds are there, and a single median epiglottic fold is there. And the posterior surface of the epiglottis is lined with the ciliated columnar epithelium, which is also otherwise called as the respiratory epithelium, because they are all ciliated to prevent any foreign body entering. And one important point about the sensory supply to the epiglottis, the upper surface or the lingual surface is supplied by the glossopharyngeal nerve, and the laryngeal side is by the internal branch of the superior laryngeal nerve. So any stimulation of the under surface or the laryngeal surface of the epiglottis in a lighter plane of anesthesia may trigger a laryngospasm. So that is the importance of this, especially in children. In those days, we used to do this called inhalation induction. So, and try to intubate with the patient breathing spontaneously. So in such cases, if you are not taken the patient to the adequate depth of anesthesia, put your laryngoscope and include the epiglottis. As you know, for pediatric patients, the epiglottis has to be included to see the visualize the vocal cord. So at that time, because it is supplied by the laryngeal nerve, they may trigger a laryngospasm. And the paired cartilages, most important of the paired cartilage is the arytenoid cartilage, because most of the intrinsic muscles which control the activity of the vocal cords, they are all attached to the arytenoid and cricoid and thyroid. And these corniculate and cuneiform, more or less, they are supportive cartilages. They don't have a major role. And this arytenoid has a pyramid shape and sits on the cricoid cartilage. It is the essential for vocal cord movement. And these two cartilages, which are also placed over the arytenoid, they more or less form a supportive role, and they don't have a major role in that. So these are all the structures which are seen even with the color coding. Now, classification and function of laryngeal muscles is important. They can be classified as extrinsic and intrinsic muscles. And extrinsic muscles, their main action is elevation or depression of the entire larynx. So when you swallow, you do the deglutition test during thyroid swellings. That is mainly by the extrinsic muscles which elevate the larynx to show whether the gland is moving along with that. And they are divided into primary group of muscles, elevators, which are called stylopharynges, salpingopharynges, and palatopharynges. And secondary elevators are mylohyoid, stylohyoid, geniohyoid, and digastric muscles. Now the depressors, which bring the larynx down, are sternohyoid, sternothyroid, thyrohyoid, and omohyoid. And intrinsic muscles, which mainly act only on the vocal cords. So extrinsic muscles move the entire larynx, whereas the intrinsic muscles act on the vocal cords to cause mainly the adduction and abduction. And so the adductors, there are three adductors. That is, three muscles to bring the vocal cords to the midline. So there are more number of adductors are there. That is why any injury to the abductor will predominantly make the vocal cord go into adduction, and that's what she described as Semon's law. And the abduction is done by only one muscle, which is called the posterior cricoarytenoid, and the tensor is again cricothyroid, relaxers are vocalis. Now this picture will tell you to describe how the muscles are acting. So you can see only one abductor, which is a posterior cricoarytenoid supplied by the recurrent laryngeal nerve. Whereas adductors you have three: the cricothyroid, lateral cricothyroid, and intra-arytenoid. And some include thyroarytenoid or external part of the intra-arytenoid also. Of this, the cricothyroid is the only muscle supplied by the superior laryngeal nerve. The rest are all supplied by the recurrent laryngeal nerve. And nerve supply to the muscles of the larynx. You can remember this mnemonic. Larynx ends with the word X. X is also way of writing for number 10. So the vagus or the 10th cranial nerve is the nerve supply, and that has got two divisions. One is the superior laryngeal nerve, and the other is the recurrent laryngeal nerve. These are the two nerves which supply all the muscles, and the only muscle supplied by superior laryngeal nerve is the cricothyroid. All the other muscles are supplied by the recurrent laryngeal nerve, and the superior laryngeal nerve divides into internal laryngeal nerve, which is a sensory to the larynx above the vocal folds, and external laryngeal nerve, which is the motor supply to the cricothyroid. And this internal laryngeal nerve only, in the earlier site we saw, we can block it at the level of the lower part of the hyoid bone, the greater convo of the hyoid bone, by injecting the drug into the thyroid membrane. The recurrent laryngeal nerve supplies the rest of all the intrinsic muscles and also provides the sensory supply to the vocal cords below the the entire larynx below the vocal cords and trachea also. And this is blocked by doing the transtracheal injection. The sensory supply provided by the recurrent laryngeal nerve can be blocked by the transtracheal injection, and the sensory supply provided by the superior laryngeal nerve internal branch by the injection below the hyoid bone. So that is part of airway block that comes under that. Then blood supply to the larynx is by two important arteries, which is superior laryngeal, which is a branch of superior thyroid, and inferior laryngeal, which is again a branch from the inferior thyroid artery. And these vessels accompany the superior and recurrent laryngeal nerves. So that is the reason why during thyroid surgery, when the surgeons try to clamp and cut the blood supply to the gland before they remove it, they have to be quite careful, otherwise they can damage these nerves, and that is the reason why the laryngeal nerve damage is very common during thyroid surgery. And of course, the venous supply is also going through all these superior and inferior thyroid veins, and they join ultimately the brachiocephalic vein. The lymphatic drainage above the vocal cords, it is superior deep cervical nodes, and below it is the inferior deep cervical nodes and larynx, and below the two vocal cords. And this anatomy is important because when they do a cancer surgery, these nodes, especially laryngeal cancer surgery, that will help to identify the nodes in the situation when they do the radical neck dissection and remove them. The secondary is deposited in that. The types of laryngeal cartilage and their significance. The cartilages are of two types. One is called the elastic cartilage, which is present in the epiglottis, corniculate, cuneiform, and the apex part of the apical part of the arytenoid cartilage. They have, they never get calcified, so they remain elastic all through the life. And the second type is called the hyaline cartilage, which is present in thyroid, cricoid, and arytenoid, except for the apical portion, which is a elastic type. And these cartilages can get calcified as age advances. And the ossification of these cartilages, even though they are cartilage, happens at the age of 25 and then gets completed at 60. That is why when the age advances, sometimes these cartilages become so unpliable, they are likely to be damaged by any laryngeal injury. The functions of larynx are protects the lower airway by closure and cough reflex during swallowing. And second is this is phonation is considered as a secondary function. Protection of airway is the primary function, and it also helps in respiration. And difference between the adult and pediatric airway is sometimes asked in the examination, and also from applied anatomy, you have to remember that. It is the subglottic area, which is the narrowest part in the pediatric larynx. And it is the larynx is highly placed in pediatric patient, C3 to C4, whereas it is starts at C4, C5 in adults. And there is a loose submucous tissue at the cricoid level which can swell up and cause obstruction. If you put a very tight tube and long surgeries, when you intubate, the patient can go in for obstruction of the airway. And the soft cartilages can collapse easily and cause an airway obstruction in pediatric patients. And the importance of laryngospasm, it is a protective reflex caused the closure of glottis to prevent the aspiration, and it is self-limited in conscious patient. So even if you get aspirated and you go for a laryngospasm, in a conscious patient, this is transient, because hypoxia and hypercarbia will abolish this reflex and restore the normal respiration. Whereas if it happens in a semi-conscious patient or in a patient in a lightly anesthetized state, that can lead to bradycardia, cardiac arrest, and pulmonary edema, especially in pediatric patients. Causes of laryngospasm can be divided into surgery-related, common in throat and airway-related surgery, thyroid surgeries, and hypoparathyroidism, or superior laryngeal nerve injury, esophageal surgery, and anal or cervical dilatation. That is a MAD procedure. Maximum anal dilatation produces a procedure done for fissure in ano, or DNC procedure, where you do the dilatation of the cervix, and that can lead to a reflex laryngospasm. What is the reflex called? Laryngospasm occurring during dilatation of the anus or the cervix of the uterus. What is the name of that reflex? Anyone? Have you heard of that, ma'am? Please say yes or no.
No, sir. No, sir.
It is called Brewer-Lacard reflex. Brewer, B-R-E-W-E-R, Brewer-Lacard, L-U-C-A-R-D, Brewer-Lacard reflex. Okay, so that is the name for this dilatation. So in those days, we used to just hold the mask and anesthetize the patient for this sort of procedures, because they are very short procedures. We never used to intubate or anything. So we induce the patient, especially in those days when only thiopentone was available. The laryngeal reflexes or airway reflexes were not suppressed like your propofol. So if you are not careful with the depth of anesthesia and you allow the surgeon to proceed with the dilatation, invariably patient will go for a severe laryngospasm and stridor will occur. And so we have to be very, very watchful while doing these procedures to take the patient to adequate depth of anesthesia. And that reflex laryngospasm, which happens when you do the anal or cervical dilatation, is called the Brewer-Lacard reflex. And the other anesthesia-related causes are inadequate depth of anesthesia, airway irritation due to mucus or blood, and volatile anesthetic agents, especially in pediatric patients. If you expose them to high concentration of volatile anesthetic agents, then that can also stimulate laryngospasm, or insertion of airway or LMA, and, or even ET tube under light plane of anesthesia. All these things will cause the laryngospasm. And the types of laryngospasm that can be classified into complete and partial. So it can be complete and partial. In complete, there is no airflow, so no breath sounds are heard during respiratory attempts. And if it is not relieved, the patient will soon develop severe desaturation, bradycardia, and cardiac arrest. So which condition can produce a complete laryngospasm, where the vocal cords are totally adducted?
In oral and palsy.
In
Recurrent laryngeal nerve palsy.
Bilateral
which type of
laryngeal
laryngeal nerve? Bilateral, partial recurrent laryngeal. Okay, this can happen in bilateral partial recurrent laryngeal nerve palsy, where only the abductors are paralyzed and adductors are still active. And that will be a deadly stage where a patient can go in for. So we have to be very watchful in that. In partial laryngospasm, there will be stridor, introing of supraspinal notch, or paradoxical movement of the chest and abdomen. And what is the pathophysiology? There are varieties of receptors present, echinoreceptors, chemoreceptors, and thermoreceptors on the posterior aspect of the true vocal cords. And stimulation of these receptors lead to glottic adduction to prevent aspiration. As I said, laryngospasm is a protective reflex. So naturally, the larynx thinks that something is trying to enter and it closes. But when the duration of this closure gets prolonged, it causes hypoxia and its consequences like bradycardia and cardiac arrest. The treatment, the common question in the examination for partial laryngospasm, identify and remove the stimulus, apply jaw thrust, positive pressure ventilation with 100% oxygen, can give Xylacard milligram per kg IV to break that reflux, or you can give propofol 0.25 to 1 milligram IV to deepen the plane of anesthesia. And Larson's maneuver. Once upon a time, it was thought it's a very good non-pharmacological method of relieving the partial laryngospasm by applying pressure between the styloid process and the angle of the mandible, behind the ear lobule. And it is actually a more powerful jaw thrust, and this causes also some amount of pain. And the pain triggers sympathetic activity, which is supposed to relieve the laryngospasm. That is the mechanism that through which it was working. So sometimes examiners ask you about the location, how do you do that, and what is the mechanism of its action. And for complete laryngospasm, first thing in the exam you have to say, you call for help. Try measures described in the treatment, but usually if it is as I said, bilateral partial recurrent laryngeal injury, it will not respond to any of this treatment. So there it is to paralyze the vocal cords by giving dexamethasone 0.5 milligram to 1 milligram IV, and add atropine, because invariably by the time you try to give dexamethasone, patient will be going in for bradycardia, and giving dexamethasone in a patient who is already proceeding to bradycardia will result in arrest. So always either proceed with atropine or mix it along with atropine so that you can avoid the bradycardia and arrest. And this will relieve immediately. You have to reintubate the patient and secure the airway. So that's all the types of recurrent laryngeal injury is a question asked in the theory examination also sometimes. So it can be classified as unilateral or bilateral. Another classification is partial or complete. So it can be 4 types: unilateral, partial, unilateral, complete, bilateral partial, and bilateral complete. So the clinical features of the 4 types are: unilateral partial is a mild hoarseness of voice alone will be there, and in unilateral complete, initially there will be mild stridor and hoarseness, but gradually it will disappear because of the compensation from the normal side. And bilateral partial is the most dangerous type, and both sides abductors will be paralyzed and adductors will act and cause complete glottic closure. And bilateral complete, both vocal cords, both the adductors and abductors are all paralyzed. So cords will come to lie close to the midline with a small gap, and patient will not have phonation. They will use the speech. And because this cannot close, aspiration can happen whenever the patient tries to swallow or drink any fluid. So these are the features of these things. So that is the details about larynx.